Welcome you all to the post-lunch session, and this is the Young Dermatologist Forum 2020, and there will be 4 presentations, and the first speaker is Dr. Chamila Ariyaratne, and she is attached to Base Hospital Medirigiri and Base Hospital Hinguraggoda, and she will talk on psychodermatology for the practicing dermatologist. Over to you, Dr. Chamila.
Thank you. Good afternoon, and let me thank the organizing committees for this opportunity. The skin is the mirror to one's mind, and the study of the interaction between the mind and the skin and the cutaneous manifestation, or psychodermatology, is now an emerging subspecialty and also plays an integral part of management in our dermatology patients in our day-to-day practice. The skin-psyche relationship is related to its embryonic origin from the ectoderm, and the physiological stressors leads to HPA axis activation, leading to a subsequent release of catecholamines and also neuropeptides and neuromediators, which acts on the skin, increases inflammation, and leads to a vicious cycle where these patients are affected again with the psychosocial comorbidities. The prevalence of psychosocial comorbidity is about 40%, and however, it is not very well taken up by majority of dermatologists. In fact, a survey conducted in India in 2010 showed only 18% of the practicing dermatologists showed some interest in psychodermatology. There are certain issues, why it is not that popular is that there are certain issues in psychodermatology. The diagnosis at times is difficult, especially for the dermatologists who are not well conversed with this subject. And in BC dermatology clinics, they tend to miss quite often. And although the best option would be to refer these patients with psychiatric conditions to the psychiatrists, the referrals are often refused by the patients as they notoriously lack insight sometimes, or because of the social stigma. So it has been identified the multidisciplinary psychodermatology teams give the best outcome for these patients, and which includes, it's actually led by the dermatologist, working in conjunction with the psychiatrist, psychologist, and the other teams. And even in the UK, there are only few well-established psychodermatology clinics, particularly in and around London. However, this is now an emerging field in the West mainly. Coming to the setup in Sri Lanka, we are yet to have multidisciplinary teams for these conditions. And also similar to other elsewhere, even in Sri Lanka, because of the social stigma, referrals to psychiatrists often is not accepted, or the patients, even at the suggestion, we might actually lose the patients in our dermatology units as well, and the patients would not go to the psychiatrists. However, in our setup, we can utilize some supportive services. There are counselors available in AGA offices and schools, and there are psychologists available in the private sector and universities where we can actually get their support if we detect these patients in our day-to-day practice or in the clinical setup to refer to the psychiatrist later. And also there is in Sri Lanka, there is a helpline which will help these patients. They can reach the helpline through 24/7, especially for patients with suicidal ideation. With that, I'm just going to move on to and see how we can increase our knowledge about the psychodermatology, and also where we can improve our psychodermatology services in our clinical setup. Coming to the classification, of course, there are a lot of conditions, but they're basically categorized into 4 conditions. The primary psychiatric disorders are the ones that we are well aware of, the dermatitis artifactors, lesions of parasitosis, where these patients have a primary psychiatric condition, but they present to us primarily to the dermatologist with multiple cutaneous manifestations. The secondary psychiatric disorders are where the patients are having dermatological conditions, and then they develop depression, anxiety, or suicidal ideations second to this. There's another category called cutaneous dysesthesias, where the patients present with pain, particularly localized to certain areas like the scalp, the vulva, and the scrotum. However, these patients do not have any underlying medical conditions or psychological conditions. And some of the conditions like alopecia areata, eczema, psoriasis, they can actually either exacerbated or even been triggered by underlying psychosocial comorbidities. In our day-to-day practice, we are more likely to come into the patients of the secondary psychiatric disorders where the chronic disorders can lead to depression, anxiety, and suicidal ideation. The association of these are well established, and active screening for these conditions and concurrent treatment invariably would improve the clinical outcome. So how can we screen our patients for these, let's see, how can we can screen these patients in our busy clinics? Of course, you can go by the clinical clues. You can take the directed history, look for the patient's appearance, whether they look anxious or depressed, and it's better to always, if they seem like, you can always ask directed questions, and particularly, you should ask for suicidal ideation. If you want to take a step further, there are patient-led, easily filled questionnaires available. DLQI is one of the questionnaires we can use in our practice. It can be used for across many dermatological conditions. And also, there are depression and anxiety scores. In Sri Lanka, there are a lot of questionnaires, such questionnaires validated in Sinhala. And this Peradine depression score is an easily filled score where we can utilize in our clinical setup. We can just give it to the patient, ask them to fill it in the waiting area and come back. It has only 25 questions, and it has taken the cultural and language factors into consideration, so can be utilized in our clinical setup. Tackling primary psychiatric disorders is difficult. These patients are difficult to handle. They would refuse psychiatric referrals often, and us, the dermatologists, plays a major role in winning these patients, in getting their trust, initiating treatment, and then subsequently we can actually send these patients to our psychiatric colleagues. To break down the monotony, this is a patient I have come across during my foreign training. Miss K, she presented to dermatology demanding isotretinoin for her severe breakouts and was wearing heavy makeup. And upon removal of the makeup, this is actually just a photo representing, she was only suffering from mild acne, which did not warrant for isotretinoin. So what should be your approach to such a patient? Would you have just given isotretinoin and get away with the patient, or would you like take a step further and see whether this patient is suffering from anything else? So this is a very classic presentation of patients with body dysmorphic disorders. And these patients are preoccupied with their appearance, and we have the opportunity to provide them the real help the patient are seeking, detect them, redirect them to the mental health care professionals, and direct them away from procedures, mainly like cosmetic procedures. So there are, like in our clinical practice, we might come across these patients in three ways. Sometimes they come asking for cosmetic procedures, restoring or enhancing a feature, or they would just go to extent length, covering their perceived faults or ugliness by wearing excessive makeup or jewelry, and or they would come with this mirror checking the habit. Why it is important that we should not miss body dysmorphic disorder is that it is actually common. It is like about 77% of the general dermatology patients are suffering, and most importantly, about 14% of patients presented to cosmetic dermatology are suffering from BDD. And often these patients are quite dissatisfied with whatever the treatment you would offer, and they would remain likely to remain with the same problem, or even if you have treated for one condition, they would move to another, and this is going to be a vicious cycle for them. And also, this is associated with high suicidal ideation and attempted suicide. So the characteristics are that they have this false belief of ugliness or deformity, which leads to these compulsive behaviors like repetitive mirror checking, which consumes about several hours a day. And they are socially isolated. because of this fear of rejection and social embarrassment. And some have the insight actually, but the others lack insight, and they can even move on to having a delusion. So the presentation would differ according to the gender. The women are more focused on their face, like acne, nose, and the stomach, and male mainly present with complaining thinning of hair and body build. Acne and dyschromia are also major concerns among these patients. So if you think about, like if you bump into such patients, we can always use some screening questionnaires, as shown in this slide, to see whether the patient is suffering from BDD. And if the patient answers to all these questions, it's more likely that the patient is suffering from BDD. So basically, they would have this, like I said earlier, the repetitive mirror checking, they're really distressed, they're isolated from their social life. And if you want to take another step further, you can use other screening tools, and it is actually advised in cosmetic procedures, prior to doing cosmetic procedures, if you feel this patient is having BDD, to go for cosmetic procedure screening questionnaires. Use this particular questionnaire. So general tips in caring for these patients with BDD, we have to empathize with the patient and act in a non-judgmental way. And we should be very careful not to comment on this perceived defect, like saying, oh, you look fine, I didn't notice it, likewise. And however, we should refraining from offering them cosmetic treatment. Ask for suicidal ideation, and if you feel the patient is having BDD, it is wise to talk to them, share your diagnosis with them, because the patients who are having an insight, that's what they want you to do. They just want you to discuss with you and get out of their problem. And of course, you have to refer these patients to mental health care experts. And in the treatment pathway, cognitive behavioral therapy, habit reversal therapy, and SSRIs have a place. Olfactory reference syndrome is a subtype of BDD where the patient presents with not anything related to their body, but they feel that they're emitting an unpleasant odor which nobody else can perceive, which can come from the body, oral cavity, or vagina. And these patients also go to length doing repetitive showering, using excessive deodorants, perfumes, and this restricts their social and domestic activities. This can be associated with other psychiatric disorders, but importantly, what we have to bear in mind if we come across such patients is that we have to do a thorough examination to see whether the patient is actually having a genuine body odor. Don't to forget fish odor syndrome. Temporal lobe epilepsy and organic brain diseases need to be kept in mind and excluded in the clinic setup. Again, SSRIs, cognitive behavioral therapy, and antipsychotics are used in the management. This is another patient whom I met actually when I was working in National Hospital. She presented with these very confined excoriations, confined to the left side of the face, and with the presentation, one would think, oh, this could be trigeminal trophic syndrome. But when I was taking the history only, I realized that she's not just picking, but she was digging out parasites that are in her face. So is it a case of trigeminal trophic syndrome? Is it delusions of parasitosis? Or could it be both? We know that these are the common patients who present with this fixed false belief of insects crawling in your skin, and they come with this very well-known matchbox sign, which is now called Ziploc sign as well, because the matchboxes are getting out of fashion. And we have to the important thing we have to bear in mind is that there can be a lot of secondary causes causing pruritus, lead into subsequent delusion. So the approach to such a patient would be, the first thing to do as a dermatologist who bump into these patients is to exclude the underlying medical conditions. You can send off the pruritus skin, perhaps do a skin biopsy, which sometimes can be quite helpful. And it is important, particularly in the young, to exclude substance abuse, because cocaine and methamphetamines, they are known to cause tactile sensation associated with parasitic hallucinations. Also, you have to primary psychiatric conditions like schizophrenia and psychotic depression can present with these symptoms. So if the patient, in addition, is having auditory hallucinations, or if the patient feels that they are being attacked by the insects rather than having insects crawling in their skin, that is a pointer towards schizophrenia. Having excluded that, you can come to the diagnosis. Once you have come to the diagnosis, the treatment, initially, it's our goal is not to treat these patients, but to establish a good rapport. So you can acknowledge the symptoms, and we should not challenge or neither confirm the patient's views about these symptoms. You can always look at the specimen that the patient is bringing, because that increases their confidence in us, and send off samples to prorata screening. And the way to approach such patients is to say that, having examined all this, I did not see any evidence of infestation today, rather than saying, look here, you don't have any infestation, it's all in your mind. So the treatment of choice for antipsychotics, historically it had been pimizoid, but because of these extrapyramidal side effects, it's been withdrawn. It's not available in Sri Lanka or anywhere common, but the second lines are risperidone and olanzapine, where we can, ideally, as these patients would refuse a psychiatric referral, it is the psychologist, the dermatologist can start this treatment starting with the lower doses, because compared to schizophrenia, the doses needed for these patients are actually quite low, and these are very safe drugs. Olanzapine can cause metabolic syndrome, so it's better to avoid this in a patient with metabolic syndrome. Morgellons disease is a subtype of delusions of infestation, and instead of having feelings insects crawling, they feel that there are fibers crawling, giving rise to this crawling sensation. Treatment is similar. The well-known dermatitis artifacta, these are the patients that present to you with various manifestation and want you to do the Sherlock Holmes work, because they know what they're doing to them, and these are factitious disorders imposed on themselves. The lesions, the clues are this: the lesions are monomorphic, they appear in crops, and the shape can be determined by the method that is produced. And not only there is an entity called bullous artifacta, where it was induced by spraying deodorants. It is said that a dermatologist is about 85% of dermatologists can bound to meet one of these patients during their clinic, during their time. And this is basically a diagnosis by exclusion. Importantly, these patients have invariably they have a psychosocial or psychiatric disorder, and when we are treating these patients, we have to address the underlying psychiatric disorder as well. They are a therapeutic challenge, and similar to other patients, first we have to exclude primary skin disorders and create a supportive, non-judgmental environment. We should avoid direct confrontation. Otherwise, this patient would go away from us and go doctor shopping, because that's what they do. The treatment-wise, we can offer occlusal dressings, and of course you have to treat those excoriations or the clinical symptoms they're presenting with. And the pharmacotherapy can include, is depending upon the underlying associated psychiatric condition. Again, excoriations are not very uncommon in our day-to-day practice, but if you see excoriations to this extent, or in a patient with very mild acne, like acne, you have to think twice and evaluate these patients for neurotic excoriations or pathological skin picking. So what happens here is that these patients are recurrently picking on their skin. However, they are also trying to reduce this or decrease these attempts of picking, and they feel they are distressed, and they feel they're socially, occupationally, and functionally impaired by this picking disorder. But investigations would not reveal any underlying physiological effects or substance abuse in these patients. So in a clinic, how can we differentiate excoriations disorder from normal picking? Instead of as opposed to normal picking, these patients will have bruises, bleeding around these areas, and they tend to pick on moles and spots, trying to smooth themselves. And they do it in an unconscious moment. And most of the time, if you ask from the family, they wouldn't see it because they are ashamed of what they're doing. So generally, they don't do it in the presence of the other individuals. And these patients tend to, sometimes some people do it as a habit. The others do it whenever they are challenged with an emotional distress. These are present in about 2% of dermatological patients, and generally the picking starts over a minor defect like an acne or scars or insect bites. And this is the classic butterfly sign is one of the presentations. And these patients, the lesions, individual lesions can have angular borders. And anxiety and depression are associated with these patients. When it comes to management, particularly acne excori is a condition where we can come across. So you have to treat the underlying condition, but at the same time, the patient should be referred for cognitive behavioral therapy and habit reversal therapy, which are the most beneficial for these patients. Another picking disorder, or a particular one, is called trichotillomania. It is very easy to identify these patients, and dermoscopy, in difficult cases, dermoscopy, there are particular dermoscopic features that are helpful in establishing the diagnosis. Not only children, but adults present with this syndrome, where the adults have a poorer outcome. The management is directed by the age of the patient. So in children, of course, they actually grow out of it. So identification of their stresses, parent education, and behavior modification are the keys in children. And the habit reversal therapy has the most effective intervention. There had been a randomized controlled trial with an acetylcysteine used in these patients, but it is not actually practiced in clinical setup widely. So if you come across these patients, there are some of the advices we can give them while they're awaiting the psychological assessment. Basically, what we have to advise them is they have to distract themselves while trying not to touch these areas. So you can ask them to squeeze a stress ball or something similar, use a fidget toy, use a bandana or tight-fitting hat, keep their hair short, and relaxation techniques are helpful. Last but not least, the cutaneous sensory syndromes. It is important to know because these patients, again, can present to the dermatologist and will be looking up to the dermatologist to get their symptoms improved. So they have these various sensations like itching, burning, and crawling sensations. And there is no dermatological or medical condition associated. This is a dermatological equivalent to chronic pain syndrome. And usually these patients, they have an underlying anxiety or depression. And if you actually treat them, the symptoms improve. So if we are to actually improve ourselves as in the view of psychodermatology, we have to get familiarized with psychopharmacotherapy as well. So all these patients I have discussed, they can predominantly have either of these underlying psychological condition, and the management would be based on the underlying psychological condition. So these are some of the very safe, commonly available drugs that is available in Sri Lanka, where at these doses we can start in our dermatological practice at the beginning of these patients' visits, and subsequently you can send these patients to the psychiatrists. Particularly duloxetine for patients with multiple somatic complaints is a very effective drug. We have to be a bit careful starting on anxiolytics. The short-acting anxiolytics should be discontinued at a very short, should not be continued for more than 4 weeks at a stretch at the maximum. But the clonazepam and diazepam are quite safe drugs to start. Patients with obsessive compulsive disorders, like trichotillomania, they do well with SSRIs. There are some the other non-pharmacological treatment. Of course, it is limited to us. We can't. These non-pharmacological treatments are generally given by clinical psychologists and the psychiatrists. So it is better to know about these and then refer the patients to these fields whenever it is appropriate. With that, I conclude my talk. Thank you very much.
Thank you, Chamila, for that excellent presentation. We have 5 more minutes and we can entertain a few questions. And please go up to the mic and speak so that the virtual participants can hear clearly. As there are no questions, so we'll move to the next presentation.